think we're going to get started. Good evening. I'm Beth Kirkpatrick. I'm a professor of medicine here at UVM and a past speaker in this lecture series. And I'm a faculty of the Division of Infectious Diseases, and I have the pleasure of introducing tonight's real speakers, Dr. Christopher Grace and our nurse practitioner, Deb Kutzko. They're going to be speaking about HIV/AIDS, how care in Vermont has changed. And thank you all for coming. I'm going to introduce Dr. Grace first. Dr. Grace attended medical school at the New York Medical College and received training in internal medicine at St. Vincent's in New York City. He performed his ID fellowship at the through the University of Connecticut at the St. Francis Hospital, and pertinent to tonight's presentation, that training really paralleled the recognition of the HIV epidemic. Following his training, Dr. Grace moved to Vermont and became the director of the Division of Infectious Diseases in 1991. The division has grown steadily under his leadership. In addition to being a skilled clinician and division leader, he's also an exceptional educator and mentor, and has led the ID training program for 16 years and been the recipient of multiple Teacher of the Year awards. Deb Kutzko, on my left, has equally impressive career. She graduated from our own University of Vermont and from SUNY Albany with her nursing degrees, and received her nurse practitioner training from the University of Colorado in Denver. Her early career was actually in the health department in Vermont, where she became the program chief of the Division of AIDS in 1986, and the epidemiology program administrator and chief of the infectious disease unit. And in 1993, she was stolen by Fletcher and has worked here since, and as you'll hear, was instrumental in the establishment of the clinic system in Vermont. She's received Assistant Secretary of Health Award for Outstanding Achievement and 2 state awards of excellence from the American Academy of Nurse Practitioners. So I've left out many accomplishments, but let me just end by saying these 2 individuals have really been an exceptional team, and they're particularly well known for their uncompromising determination to bring great HIV care to Vermont. And with that, I'm going to turn this to Dr. Grace. This to Deb.
Beth, thank you very much for the very kind and generous introduction. I'm going to finish the introductions just by introducing Brad, who is on the far left, and Tim in the middle, who are 2 patients of our comprehensive care clinics, which are the HIV care clinic systems in the state of Vermont. They've been patients with us for many years, and I think from the perspective of tonight, they bring a lot of experience of what we will be talking about. We are going to change the format around a little bit, and we're going to talk about these various issues, but we're going to break it from an hour lecture and a half hour of questioning to an open forum. And so think of the slides that I will be using as sort of a structure of a building, the skeleton of a building, that then Deb and Tim and Brad will be filling in their experiences, and they will jump in and jump out as we hit various topics. And quite frankly, I will be doing the same because I probably can't keep my mouth shut. But on the other hand, we would encourage participation from all of you. So this will not be a formal, you ask questions later, you can ask questions now, you can give your own experiences if that is pertinent to the discussion. And we may weave in and out of these topics as we go forward, all right? So if we run the entire hour and a half without a formal question and answer period, hopefully that will be built into the process as we go along. So I'm going to start with the history. And indeed, although the title of this is the 25 years in Vermont, we're going to go back a little bit further than this. And this slide is a copy of the original publication from what was referred to as the MMWR, this is the Morbidity Mortality Weekly Report, published by the CDC in 1981. And on the second page of this publication in that year, there was a report of 5 young gay men who came down with a very unusual, what is now known to be a fungal infection called pneumocystis carinii pneumonia. And they were also found at that time to be very immune suppressed. So these types of infections never occur in otherwise healthy people. We used to see them in years gone by in people getting cancer chemotherapy, or they occurred after World War II in people starving and with malnutrition. But not up until then was this seen in otherwise healthy people for no reason. Shortly, that was followed by other reports by the CDC. So this is then looking at shortly thereafter is that they started seeing an unusual type of cancer called a lymphoma also in gay men, and then further a very unusual cancer called Kaposi sarcoma that I'll show you pictures of later, also in gay men, not only in Los Angeles, but in New York and other large cities. That was then followed by finding similar types of illnesses in people who are hemophiliacs, meaning that they have a clotting disorder and they must get huge amounts of blood, particularly clotting factors in their blood, transfused into them. And then also finding these similar types of infections in prison inmates, female sexual partners of men who had these infections. And then finally in 1983, there was felt to be a linkage to a virus. So I thought that we would take a moment and just talk about these things a little bit of what was going on and what was happening, and we'll start.
Yeah, I think in the very early stages, it was, it's hard to think about this retrospectively, but in the very early stages, it was page 6 news for us. We were living in Vermont, and there'd be a little blurb about these things, 5 men, Los Angeles, gay, was it a coincidence? And it was over a period of time, year or so, it became persistent and getting closer and bigger in our heads, but nobody really, we had friends who died, but were not diagnosed as having AIDS until many months after they had died. You know, I mean, it was just this mystery. They had a pneumonia that could not be cured and was resistant, and then their partner had a pneumonia that couldn't be cured and was resistant, and people started dropping off pretty quickly, and yet it was a mystery to us. And I think that it seemed far away for quite a while. I could not tell you, and maybe you can remember, when it became present to us. I mean, exactly like, hey, is this going to happen? Or is this happening to everybody? You know, I mean, there was some sort of moment when you realized, perhaps that 4 moments ago, you had come to the realization that it seemed to be happening to everybody that you knew. And how could that be? I mean, really, what would that be? That to be in the middle of a plague in modern times when you've always had your shots and gone to the dentist twice a year and, you know, had good health care and did what you were supposed to do, and suddenly I'm in a plague, you know, it just seemed unreal to us.
So I was, no, okay. In 1984, I went down to Boston to work in the Fenway Community Health Center, which was still is the Gay and Lesbian Health Center in Boston. And I went down to do women's health care because that was what I was doing. And within months, it became very clear that the guys were dying, that we were facing an epidemic that we had no idea what was going on. You know, we now, and Dr. Grace will talk about CD4 counts and T cells and parts of the immune system that nobody really paid any attention to before because we were dealing with young, healthy people. And we were learning terms that we didn't know about, and soon after I got there, the Centers for Disease Control picked the Fenway, because it was the Gay Health Center, as a place to do some of the emerging research. And by then we sort of knew it was sexually transmitted. It was after the discovery of HTLV3, and so we knew that it was viral, but we didn't know how to cure viruses. You know, we still don't do very well with viruses. We can't cure the common cold. We had no idea what was affecting these folks, and got very good at learning how to help people die, to help people wrap up, I was an expert at talking to young men's mothers about the fact that they had this disease, and we could deal with the pneumonias, but we couldn't keep them from coming back.
And, yeah, I think also, during that period of time, before it was identified, people did not know what was going on. There was a test eventually that you could find out if you were HIV positive, but here in Vermont, there was nowhere to go. No, the doctors didn't know. The healthcare system wasn't set up for it. We'd had a general practitioner for years, and when we were diagnosed, we went to the general practitioner. He had no idea what to do. We ended up going down to Fenway because you went to the urban centers where you had a hope of somebody knowing something.
We kind of put this in perspective. Within 3 or 4 years, we didn't have, or 5 years maybe, any friends alive. Every single one of our friends had died. None, not one, left standing. We felt like we're in the middle of Hiroshima, and well, how come it didn't hit us? And that's why now all of our friends who are gay are younger than we are. I don't think we have any friends who are our age. That's how vast when it hit. That's how prevalent it was. It wasn't small. It was as if when you were 30 years old, every single friend you had ever made in your life was dead in 4 or 5 years. It felt like a plague. It felt like the middle of medieval plague or something.
And when I was a house officer doing my internship in internal medicine, I was in New York City at St. Vincent's Hospital, which was the hospital that was right in Greenwich Village, which was the heart of the gay community. And from 1979 to 82, I was there, and I remember distinctly having these young men come in with illnesses that we didn't know what they were, or we could diagnose them, but had no idea what was going on. So the mystery and the fear was palpable. That in our intensive care unit, we had a 20-bed intensive care unit. Half of it was filled up with young men dying of these horrible infections, and I'm going to talk a little bit later, and everybody died. Just flat out, everybody died. And the mystery of what was going on, no idea. We'll go back to some of these things as we move along.
Tim's got one more.
Go ahead, I'm sorry.
There's one thing, when I was newly diagnosed, I thought, well, maybe I should get some help dealing with this or something. And I went to a therapist in town who I knew was gay and had, helped people in the gay community. So I made an appointment and go in and say, okay, I'm here. This is what I'm dealing with. And the immediate response was, I can't deal with it. I've had too many friends die. You'll have to find somebody else. And I was thinking, if you can't, I'm paying you to deal with it. But that was the mindset that was going on at the time. And it's kind of hard to imagine now, but it really is that there was nowhere to go for help.
So when this is all going on, there was a lot of terrible politics going on. This is Ronald Reagan era and so on. But at that time, science kicked in very hard. And from 1981, when this was first described in the MMWR, to just a few years later, they isolated the virus that caused the disease. That's almost unheard of to go at that speed. And it was originally called human T leukemia virus because it was in the same family. I'm going to touch on that a little bit. But to be able to isolate the causative agent of this and nail it down through epidemiology, and then also within a very short period of time, again, 1981 to 1987, the first drug was released. It was not a very good drug, and it had a huge amount of toxicities, but it was a start. So the science kicked in very hard. I don't think society kept up with that, but it did. So I'm going to pivot here a little bit and just talk about the virology and the immunology a little bit, just so you have a feel for some of the terminologies that may be used as we go along. And I will go through this a little bit quicker so we can be done with it. But the HIV, the Human Immunodeficiency Virus, is a virus. And I'll talk a little bit about this. But just to give you some perspective, there are bacteria, such as staph and strep infections of your skin. There are parasites, Giardia, you get from drinking bad water, for example. There are fungi out there that people can get yeast infections, for example. And then there are viruses, and there's scores of them out there. There's influenza that we're moving into the season now, viral hepatitis, cold viruses, and HIV is a virus. These are microscopic, basically pieces of protein and nucleic acid. They really cannot survive by themselves. A bacteria can survive by itself. These viruses cannot, and they must have a host cell, us, to replicate in. And they're basically made up of genes, predominantly with RNA in the middle. They have a protein coat on the outside, and then they have an envelope. And that envelope basically acts to protect it and attach to our cells and allows the ribonucleic acid, the RNA, to enter our cells, which I'll show you. So these are basically replicating machines. So this is what a schematic of the virus looks like. It has 9 genes in the center, and it has a couple of proteins, glycoproteins, sugar proteins out here that allow it to attach to the cell. So it must go pretty quickly from cell, blood, to get into a cell pretty quickly. Otherwise, that piece of particle will die. So it needs to get into us very quickly. HIV, or called the Human Immunodeficiency Virus, its newish name, basically leads to an end stage of illness called the acquired immune deficiency syndrome. So this is a continuum from initial infection to full-blown aggressive disease. They are not two separate things. It's sort of like having somebody with a localized tumor, if you would, and metastatic tumor. It's the same tumor. It's the amount of spread and destruction that it does, and I'll get back to that. Just to get into this a little bit, HIV is referred to as a retrovirus. You will hear us talk about retroviral agents. The reason it is a retrovirus is that it acts backwards. So here is normal. We are normal. Our replication pattern is normal, and we must start, as in our genetic material, we have DNA, and in order to replicate, we must make a copy of RNA and then protein, and that's a standard pattern in us as humans, most bacteria, fungi, and so on. That's the normal system. HIV goes backwards, and it has, as its core, ribonucleic acid. So it's starting at sort of this step without that step. And in order to replicate, it must go backwards. Normally you go DNA to RNA, it must go RNA to DNA. And it does that through certain unique enzymes, and then it will make protein and replicate. This process of sort of this backward step is therefore why it is called a retrovirus. And there's a number of different retroviruses out there. This is just one of many. It does it through certain enzymes, which I'm not going to get into here. So I just put that out to say that it works backwards. The drugs are named retroviral drugs, or highly active antiretroviral agents, and that's where the terminology comes from. And just to look at this, this is the virus now, and it has inside here its RNA, and it has on these little knobs the attachment sites for it. And it comes into your cell, and this is one of, say, like your immune cells here, and it gets in and it starts replicating. It goes the backward step from RNA, eventually makes DNA, and then that DNA is integrated into your genes, right into your chromosomes. And so when this cell is minding its own business, and here's its nucleic acid, the virus, HIV, is integrated right into those cells. So if this cell is turned on, and it's immune cell, so if it sees another infection, a cold virus, something, and this cell turns on, those genes, those viral genes, are turned on, and they start making copies of the HIV nucleic acid. It then pops out of the cell, and when it pops out of your cell, it drags some of your cell membrane with it and steals it, and then it replicates. And this can go very quickly, and literally 10 to the 10th viral particles can be made every day. 10 to the 10th. That's billions and billions of viral particles can be made every day in somebody. So it's replicating very quickly, and it can spread to all the other cells very quickly. Basically, HIV attacks the immune system. So what is the immune system? The immune system is a complex of cells and proteins that fight infection. And they can not only fight infection by directly attacking a virus or a bacteria, but they can also kill the cells that the virus get into, and they do other things too. They scavenge abnormal tumor cells and kill them so the tumor doesn't propagate. And these are made up of white blood cells shown here. This is a blood vessel. You can see the red blood cells here. You can see white blood cells in there. Those are part of the cells that make up the immune system, and they can go and attack viruses and bacteria. And then we have certain types of cells that secrete proteins that are important. And particularly important are these T cells, these lymphocytes. And those are key to the immune system and coordinating the whole process. And one that I'll tune into, and the terminology is important because we use this all the time in the clinic, is certain cells that are called T cells or CD4 cells. Those are sort of the linchpin of the immunity, and it is this cell that is attacked by HIV. And so this is sort of shown, well, in cartoon form here, and think of that this blood cell, this T cell, is sort of like the quarterback of the immune system, and that T cell is coordinating your antibodies, other parts of the immune system, and so on. And if this T cell or CD4 cell is damaged or is killed, then the entire immune system disintegrates. And what HIV does is it attacks that cell. So I think, Brad, you were using, a tsunami analogy of what was going on to the community, but this is happening in people's body when this virus, it's like a tornado, and these are supposed to be representing the T cells that come in, and they destroy these T cells, and therefore the number of T cells in your body goes down, and we can measure that. And this is what they found in the young men in 1981. They had these terrible infections, and when they went to measure how many of these cells were around, they found none. And so this is a cartoon, again, showing that HIV is attacking that very important immune cell, the T cell here. And then what happens over time, and this schema is about, say, 10 to 15 years. Normal T cells are about 1,200 to 2,000. That over time, the HIV is coming in here and attacking that cell and killing it. And our body is trying to make more T cells, but more viruses are made. They replicate very quickly. And over time, that number falls. And it falls, and it falls. And at some point in time, it reaches a level where your immune system starts malfunctioning, or it just can't fight off the infections. And usually when that number falls to about 200 or so, that people start potentially getting sick. So in this early phase, this is HIV infection. The virus is there, the Human Immunodeficiency Virus is here, and it is attacking T cells. And once it falls below this level, people start getting sick with these awful infections and sort of move into a later state of age. Now I'm going to put these gentlemen on notice a little bit, but can you tell me what your early T cells were, and did you have an understanding? We didn't prep this question, but can you talk a little bit about that? And even current, Brad, if you're comfortable with that.
Well, early. Well, by the time we got tested, we became aware that you could have this for a number of years without anything showing up, so that it was kind of incumbent upon us. We had been together for a while, for several years, but we could have been carrying it around from years before. So that's, it wasn't like catching a cold or something. At first we thought it was maybe a sudden thing or more quick thing. You figured out that you had it because you started getting sick. And then when it became known that it took this long to incubate, that people maybe had it for 8 or 10 years before actually it showed up, that was then it became incumbent upon us to get tested to find out, well, where do we stand? By the time we got tested, our T cells were 200 to 300 range.
Around 300, I think, yeah, 3 to 400.
Mine a little lower, maybe. Yeah. And so, and by the time we got, you get, first you're tested that you're positive, and then you get tested, and then you go into more testing about what you should do about it. At that time, when we were tested, we felt that we were going to, I don't know if this is a good time to talk about this, but we felt that we were, I mean, everybody felt like, okay, you're pretty far down the road with this as far as T cells, and although people were kind and hopeful and everything that, you know, clinicians should be, nobody was really saying that we were going to live very long. You know, I mean, it was kind of...
And, you know, a thing to remember too is the T cell test, I believe, came before the viral load test. So you knew what your T cells were, but you had no idea what kind of viral load that you had. And even with a low viral load, you... 86 is when I was tested. 86, and my T cells have stayed fairly within 100 points, fairly stable from then. My viral load has changed a lot.
And if I could just interject a word, I'm going to talk about viral load in a minute, but that's a measurement of the number of viral particles per unit of blood.
Yeah.
So we can measure that, but that test was not available
Right.
at that point in time.
Yeah.
Yes.
Yeah.
So how you got, back then, and it was, I didn't fault anybody for this little snafu, but what happened was you went and got your blood tested, and a number was assigned to you.
By the state health department.
State Health Department. So a number was assigned, anonymous, because anonymous testing, of course, was the right thing to do, because if you weren't tested anonymously, maybe it could be used against you. People thought that it was easily communicated, and I think Deb is going to talk some about how easily it isn't communicated. But who knew, you know, back then? So, so you get this number, and then you give it a couple weeks. It took a long time, or 3 weeks, and then you call up the health department. And you just say, "I'm number such and such and such," and nobody told you your results on the phone, because if they said you were okay on the phone, that meant that no, we need to tell you in person. That meant you weren't okay, so you had to live to the meeting, and then you'd be all upset and everything. So everybody had to go for a secret, anonymous meeting to find out your results. Now, unfortunately, or you know, Vermont was Vermont then. There weren't that. We were in the early. I called up for both of us, gave the numbers, and the person on the other phone, some young guy, put his hand over the phone and said, "I've got the positive ones," you know, like this. And I'm hearing it, and I didn't. And I thought maybe I didn't hear that. Yeah, maybe I didn't hear that. Maybe really what I heard was, "I've got the not positive ones," or something. I don't know, but I knew I heard it. But I didn't tell Tim. One of the deceptions we do for each other, you know. But we made it. The deal was, the person told us the make and color, model of the car, and then we told them our car, and then we had to go park after hours in the Gutterson Fieldhouse and find each other's car. No, I know, it was like a spy movie, and I kind of already knew the answer, but I was, you know, this was 3 days later going, oh man, this is going to be a bad meeting, but, you know, trying not to believe that. And so we find the car, and there we are. We park next to only cars in the parking lot. We were next to each other. He gets out of his car with a folder of support materials and people, and gets in the back seat and says, "Well, I've got disappointing news. You are positive." You know, but he could have said, "I've got great news. You're not positive," but he said that you are positive. So Tim was driving, and Tim was like, oh, and I had kind of prepped a little bit for this since I had already heard it a few days before, and I was going, oh, yeah, well. And I can remember he was really very nice, and I never told him. He let the cat out of the bag. But he said, but I've got some handouts for you, and I've got this and this. And we said, no, that's fine.
We need a drink.
We need a drink. No, actually what we needed was food. I come from... when I'm depressed, I eat, and when I'm happy, I eat. I just kind of always eat. And so the guy gets out of the car, took all his brochures with him, and Tim was like, oh my God, what are we going to do? I said, this was when I was still in business. I said, I need to go to Howard Johnson's now. You know,
But let me, if I could interrupt a little bit, just to say, this is 1986?
86.
Okay, so at that time, people are dying, there's no medicine.
So that's what he's telling you. I was going to say, okay, good luck. You're going
Right,
to,
there's no medicine. That people have been shown to die from this. These guys get told that they have an illness that they're going to die from, and there's no medicine.
But there's food.
It's food.
And there's only so much food left, apparently, in our lives.
And, you know, maybe Deb could jump in here too, but
So there's a question in the
in
audience.
the older days, it was not uncommon for people to present for the first time with a T cell count of 10,
Yeah.
25. You know, we facetiously said if they're below 10, you can name them. But
That's right.
people were presenting oftentimes very late. And this is still happening, much less than it was, but we have people being admitted to Fletcher Island every year with very advanced disease and essentially no immune system left. Thank God we can, within reason, fix that, but
And this was also, I mean, this is still, people were figuring out what was going on. Gay culture was very different back then. And if you were following news or leading, you know, trying to find out what was, you know, there weren't blogs, there weren't things you could read that was going on, but one of the magazines that came out was called The Disease Pariah. And that had information in it about...
It was an ironic title. It wasn't serious.
So first I want to apologize because I created that system when I was at the health
If it weren't for that, it would have been fine. It just, he didn't cover it tightly enough.
But the reason we created that system is that nobody was getting tested. Sorry, thank you, Tim. That nobody was getting tested. And the reason nobody was getting tested is that everybody was in a panic. And that, quite frankly, in those days, if you went to your physician, it was not unheard of that the physician was as scared as you were.
Yeah.
And so we knew then, and we know even better now, that this isn't transmitted by casual contact, by coughing and sneezing, and I have had patients throw up on me, and I have had patients cry, and none of that is an issue. It's blood, and it's semen, and it's vaginal secretions. But we weren't secure in that knowledge back then. I mean, science was, but the population wasn't. And it was hard to believe that something that could be so devastating was not easy to catch. And so people made sort of that leap in their mind that if it was deadly, it must be easy to catch. And so we had to find a system where people could get tested and not deal with all the prejudice that was out there. And that was the first thing. And yes.
I just want to throw in, too, there was a reluctance to be tested because even if you found out,
There's nothing we can do.
what do you do?
Yeah, exactly. And so we had people coming to us who were diagnosed, and again, who had very few T cells. And there wasn't anything we can do. And the paid political announcement here is that the reason that we continue to have people who come to us with less than 20 T cells is because there still is not enough HIV testing in this state. And we'll talk about that later. But this is now, if caught early enough, a chronic disease, manageable disease. And physicians still don't test their patients.
right, and I suspect at the rate we're going to get to those points at about 12 o'clock tonight.
But there was a hand up, Chris, and we invited questions from the audience. There was a hand up.
True, sorry.
You might have answered it, but were you meeting at Gutterson because people were afraid of catching it, or?
No. It was a place where you could meet anonymously because it was after, nothing was happening in the parking lot. I mean,
It was night, it was...
night, it was, you're the only two cars there, so it was just a place.
Anonymous place.
And now, what, you could, you know, we understood why that was there. It was because you didn't want, if somebody saw you with a person they knew worked at the health department whose job it was to deliver this news, suddenly rumors would be out there. And a rumor about this at one time was terrifying. Everything, I mean, people, it's hard to imagine for us how frightening and how frightened people were and how frightening it was for us to have people that frightened. You know, it was a panic
And
out there.
also, I think something that figured in it for us is, you know, it wasn't out, is that at that time, we're retired now, but we were both teachers. And you would read in the papers Ryan White, who was getting his house stoned or getting thrown out of schools, or
And
all
we'll
that
talk
kind
about
of-
him in a
and
little
just
bit.
the kind of reaction.
Demonstrations outside of classrooms, you know,
Yeah.
be like, oh my God.
Yeah.
The other thing
Something you didn't want.
from a provider point of view of giving news is that we always gave this news, and we still do, face-to-face.
Yeah.
So you might get a call from your docs about your blood counts or whatever test. We never do that. We always do face-to-face. And from a provider point of view, our major fear is that people would commit suicide.
Yeah.
And so, and that was uncommon, but it did happen, and that was our fear. So we would try to meet face-to-face to get people at least supported and have a structure around them. So if things are unstable, and many times they were with this news, again, we were giving people a death sentence with a completely socially unacceptable disease, discriminated disease, horrible stuff. So we were really quite concerned about that, and that's why a lot of this was done face-to-face.
What was that like for you, Chris, Deb, to give that death sentence? I mean, you must have done it many, many times.
Many times.
You must
know.
have, I've never asked you this, but did it, before going into that, was your stomach, was it like, did you have to steel yourself up for it?
Yeah, I mean, it was very difficult, and it remains very difficult. No one likes giving bad news about anything, but this was very difficult. But we would clearly be in a different mindset, which was, how can we deal with the consequences of that disease diagnosis? So we were thinking differently of how can we support this person, and then later on about what we can do to prevent the deterioration that happened to people. But it was difficult, and there was a lot of anguish and a lot of tears, and there still are. And not only for the person who got that news, but if there's a family member, what would happen with that? You know, families were ripped apart with this news. Very difficult stuff, and it quite frankly persists. But just to finish this out, and so here is what I was talking about with the T cells falling down to very low numbers and people getting full-blown AIDS with these awful infections that we'll touch on. The viral load is the amount of virus in your blood, and it spikes up, but eventually it'll continue to rise. And as that viral load gets higher to 10,000 copies, 100,000 copies, million copies, the more viruses the more viruses can attack your T cells falling down. And we can now measure those things and use them.
Mutate.
So just to sum up this part of it, basically, if I could, HIV is the virus. It leads to this acquired immune deficiency syndrome. It does that by destroying your T cells or your CD4 cells. And then the syndrome is the diseases that people get. It's not so much the HIV virus, but it's the diseases you get from having a damaged immune system here. And classically, we get these horrible infections called opportunistic infections because they take the opportunity to infect you because your immune system is damaged. And I will show you pictures, and some of them are pretty graphic in a little while. But, certain types of pneumonias, brain infections, eye infections, really very difficult stuff. So this tore people to pieces. So any questions or comments? Because I'm going to pivot again. And correct. So the question was on the slide, this slide, that there's characteristically a dip down of the immunity. So the virus comes in here. You actually, and this is one of the mysteries, is that your immune system actually has a robust and vigorous attack against the virus. The virus is able to evade that, and no one has really figured out how the virus does that. That's the problem with creating a vaccine, is that you got to know the immunologic mechanisms, and no one has figured out why the virus gets in there and dodges it. It's probably because of the rapid mutations of the virus. But then your immune system comes back, and it challenges it, and it controls it to some extent. You can see actually the virus will plateau for a period of time. It may be very high, but it will plateau. During this time, though, from here all the way out here, and this is 10, 12 years, whoever has this is asymptomatic. And that's one of the problems. So they're not sick, and they may not have it, and therefore can't transmit it or don't come in.
Do you know if you're in the first year or 5 years out?
Within reason, we can take a guess at that within reason, by looking at, what your T cell number is. And some T cell numbers, I've seen people with the same T cell number for 25 years not on drug. And I've seen people go down pretty quick. So it's variable, but we can guess at that. So from that beginning, 5 men in 1981, this is looking at the world of the amount of HIV in the world. And you can see that this number is out in the territory of about 30 million patients worldwide with HIV. So from the tiny beginning, it has really taken off, and it has gone from a disease in gay men in the larger urban areas to everybody in the world. And this is looking at sub-Saharan Africa, which has about 13% of the population, while it has about 67% of the HIV infection worldwide. The majority of the people in sub-Saharan Africa with HIV are women, about 56%.
I lived in Swaziland for 2 years, and it has the highest prevalence as it now is famous for all the wrong reasons. I was going to funerals every weekend. I had to skip them. So, that's in perspective.
And that, it does put it in perspective. And that, unfortunately, in many areas of the non-United States, non-Europe, that continues. That continues. So this is a worldwide disease, and when you look at the world population, the biggest population of people that are sickened by this are heterosexual women. This is looking at the United States, and this dotted line is the number of new cases. We'll go back to that every year, and this is the number of people living with HIV. And you can see two things from the 1970s up until the current point in time, is that the number of new infections in the United States has not gone down. And that's despite literally billions of dollars put in terms of education, risk reduction, et cetera. It has not gone down. And so a new thought process, which we'll talk about if we get to it at the very end, needs to be put in place. But because the drugs we have, that we'll touch on, are really working very well, instead of everybody dying, people are now living. So the number of people with HIV is increasing. And we have seen that in our own clinic because people are still getting infected, but they're no longer dying. And that will continue. And as we get more and more medicines into sub-Saharan Africa, India, China, other areas in Southeast Asia, that should continue also. Also, this is looking at who it does affect in the United States. And you could see basically right at the beginning here, 1985 or so, it was predominantly a disease of white men, white gay men. As Brad and Tim were saying, a lot of those men died. And that's one of those reasons this number has come flying down like this, is that they died. But on the other hand, there has been, I think, and maybe you guys could talk about this, that there has been work within the gay community to try to stop this from happening. But where the epidemic in the United States is going is into the black community, particularly black gay men and black heterosexual women. And indeed, the largest rising population in the United States is in the southeastern United States in heterosexual black women. And there you can see that's a nice curve. This is not such a good curve of rising problems there. So the epidemic is changing as time has gone on. Any comments, guys? Should I move on?
Well, you talked about the work within the gay community. We were aware at one time of a lot of work within the gay community, but I'll be honest, as you become older, you become, I don't know, you just take care of your garden and you make sure your dog gets let out. You're not as involved in any community. So we're less aware, I think, of what's happening. We're just two old guys live on the hill. So, but a thing I worry about is that as, it became obvious that it could be managed as a disease, and also that perhaps even some drugs could be used prophylactically, that there may be another spike coming for gay men because it doesn't pose the same danger as it did before. If you have health insurance, you have access to drugs, or maybe you have access to drugs after early on that could prevent you from transmitting it or getting it. And I think the jury's still out on that one. I think there's a lot of fights going on about whether or not health departments should be optimistic about how good the drugs are, or still, being the harbingers of danger out there. I don't know where you are in Vermont about this.
Well, we continue to see young people coming in. I think it's less than it was before, and it goes from the spectrum, and Debbie, you can comment, from, the devastating effect of getting that news to, I've had, young men sort of go, whatever, because these drugs are very good, and they know that they can go on these drugs, but we'll get back to that if we could. This is just a slide. I put up the slide about Africa and the devastation that is occurring in sub-Saharan Africa, and I think, we're talking about these high rates here in many countries of sub-Saharan Africa, but there are pockets in the United States that are that hit. And this is looking at, say, like New York City and also in Washington, D.C. They're approaching levels of infection that are as high or higher than in many parts of sub-Saharan Africa that have no health infrastructure. So there are terrible pockets here in the United States. Sir.
Is there any sort of socioeconomic correlation with black men, black women, as opposed to white men or whoever at this point?
You want to take a whack at that?
I think there's two things. I think that folks who are of a lower socioeconomic strata don't have access to health care. And so in some cases, the infection, they don't get treated, quite frankly. And that's not only true of HIV, that's true of everything. I think that for some women, they don't have an option of safer sex. That for many women, particularly women who are in abusive relationships, they have sex the way they're told to have sex. When people we have lots of people in this country who exchange sex for a place to live, for food to eat. I think all of those things make this harder. And I think that, again, people are just not getting the care that they need. And a lot of that has got to do with poverty.
What year did they start really testing blood and transfusions? 84?
Was it 84 or was it later than that?
It was a great debate at the Red Cross in probably 84, 85, in which the Red Cross was denying that this was bloodborne. And it actually took a pediatrician in New York to say, babies are getting it. So we know it's prenatally transmitted. And certainly the hemophilia community was vocal. It took, I guess it was probably the test came out in 83, and it was probably 84, 85 before the Red Cross. Now, of course, there's no worry at all on the blood supply.
So just looking a little bit more at this. So this is the United States again, roughly about 1 million people infected, living with this, about 50,000 new infections a year. But this is sort of the problem here, is that people with HIV not in care, 40%, it's a huge number, are not in care. And those are people who know they have HIV and are not in care. Why is that so? A lot of it is economics. A lot of it is lack of health insurance. The Ryan-White Care Act that we'll talk about later is this push to get people insured so that they'll come to the doctor. A lot of people are not getting tested, but this is a big chunk of people here who are not in care. And then there's another 20% or so of them that don't even know they're infected and have not been tested. And therefore, all these folks are at risk for further transmission because most of those people remain feeling well during the time that their T cells are falling down. So that has not changed. We'll go back to that as we go along.
And I think later, Chris, because some people are probably running through their minds, well, what about Vermont and, how does this, you talk about New York, that I think later you're going to talk about how to deliver services, are you not, to rural?
We're going to
which
try,
is
if we get there.
Because that's another huge block if you live
Right.
in many states, if you lived in a extremely rural place, how would you?
Yes.
How do you estimate people with HIV who don't know they're infected?
These are estimates, so they can do population studies and test people, just take groups of people and test them and say, these are the number of people that we tested that knew they were already positive. We have found another 10, 15%, 20% of people who just found out right then and there, and then you extrapolate that to the general population. So for example, in Vermont, they estimate that we have about 500 or 600 people infected in the state, and there's probably about another 100. But these are rough estimates. So this is, I think, a slide showing from a little bit longer ago to sort of more current times with these medicines that we have and people living longer, is that the age distribution of our population of people who have HIV has shifted. And these guys are proof of that. And you can see that where this box is, that there's large numbers of people now with HIV who are into the older population. And that is obviously a good thing because that's what we're all supposed to do. But it makes the complexity of care from a provider point of view different. It's one thing taking care of somebody who's 22 years old and is otherwise perfectly healthy except for this virus versus somebody who is 65 years old and has hypertension, hyperlipidemia, and so on. So the medical care is shifting as all these other things are shifting in a good way. But the epidemic, the characteristics of the epidemic in terms of race, ethnicity, age, gender are shifting as time goes on.
This is one of the few situations where you're really happy to find yourself in an age distribution, to be in the farthest cohort to the right. You know what I mean? It's like,
And just getting closer to home, this is our clinic population, which is reasonably the best idea of what is happening in Vermont because of our clinics see most of the folks. And this is going back to '95 when we started our outreach clinics. And in the bar graph here is showing the number of new patients coming into the clinic. And again, just like the United States, it goes up and down, but it really hasn't changed very much. It's not like it is plummeting down. And you can get a feel for things. I'll give you a little bit more data on this while, but over since 1995, you can just see what's happening in terms of the numbers as we get better with these drugs and people survive, particularly if we can get folks in. And there's no sense that that trend in numbers is going to change and go down over time. So I'm going to pivot again. Anything else? Any questions at this point in time?
The numbers when we're looking at those infected, is this just sexually transmitted or is it also intravenous drug use?
Most of it, at least in Vermont, is sexually transmitted. About 15% of our population is infected by injection drug use. But of that sexually transmitted, about 55% of that, of our group are gay men. But there's a big section of heterosexual men and women who are infected also. And then there's a smaller group, about 15%, who are infected by injection drug use. And honestly, it's sometimes hard to dissect all those issues out. And a lot of times, this is so difficult a topic that we're bridging into that particularly early on, I just don't go there. That's the least of the issues. We've got to deal with the current issues, which is this virus. And so we don't, oftentimes I will not go into how'd you get this or whatever. It's sort of a moot point at that point in time. But there's clearly injection drug use. If you read the papers, you can see Rutland County is having a big problem. Chittenden County is going to be having a big problem. And the feds who study these things in Vermont suggest that this is going to be an increasing problem in the state. And therefore, it'll be an increasing problem in terms of transmission for HIV, hepatitis B, hepatitis C. I'm going to show you some pictures. Some of these are graphic, and I intentionally put them as graphic because this was awful stuff. This is before our drugs, our good drugs, and I'll talk about that. Here's that word retrovirus. HIV is a retrovirus. These are drugs that are anti or against that virus, and that's where the terminology has come from. You've heard of the highly active antiretroviral therapy or HAART therapy. It's referred, I hate this term, as a cocktail But this is before this time, so giving a feel of what was going on before 1995 when these new drugs came out until now is that before this time, basically we had very crappy therapy. We had pills that worked, but they worked over very short periods of time. They were incredibly toxic, and it was difficult. And then people were getting these horrible infections that I'll show you a few pictures of, and then people were dying. And that was what was happening in terms of the transition. And basically what Deb and I did as providers, particularly through the 80s and early 90s and mid-90s, is that we were hospice providers. And we spent a huge amount of time, we'll talk about this later, walking people through their death. And it was very difficult, not only from the patient's point of view, but this ripped families apart, and we can give you anecdotes of some really horrible things that we saw in interfamilies. Some families rallied, and they were inspiring. And some of the men and women, but predominantly the men that died, were inspiring when they faced this, because just like these guys, looking at the devil right in the face and knew that they were going to die when we diagnosed them. So we spent a huge amount of time doing that. And people would die of pneumonia. This is an x-ray. All this area that's all whited out is supposed to be black on the x-ray. All this white is infection, and then basically their lungs would be filled up with these horrible fungal infections, and people would smother. People would get Kaposi sarcoma. This is a tumor that used to be diagnosed in Mediterranean men and was hardly ever seen. And if any of you saw the Philadelphia story with Tom Hanks, the sort of social stigma of being scarred with this. These are lumps. They're not particularly painful, but they could be right in very prominent places here. And you talk about having a scarlet letter on your face. It doesn't get any more obvious than that. And then it could get really bad. And some of my most horrible stories and images of this would be this extensive amount of Kaposi sarcoma that would happen is that these men, predominantly men, would come in and would be caked on their legs. And their legs would start bleeding, and we couldn't stop it. And the pain was excruciating. And people would die these horrible deaths. And it was awful. And I hate to be so graphic, but in terms of what was happening, what it was like, for the patients, for us trying to deal with this, it was really awful stuff.
Walking in streets of New York, and especially in certain neighborhoods, you would see lots of people. I mean, it was not a rare thing to see somebody with a cane or a wheelchair or just walking very slowly. It was covered with these lesions and sort of soldiering on and in a way inspiring, still, out there trying to face the people staring at them and kids pointing at them and stuff.
Right, and when we had our early, I'm sorry, Tim, but when we had our early clinics down at the UHC building, we actually had our own little hallway and our own little waiting room because some of these men and women were terribly disfigured or looked, quite frankly, awful. And when we designed these clinics, these outreach clinics, we said, where are we going to do this? This is a digression on a digression, because we can't go to somebody's private office and have a whole bunch of people sitting there and, quite frankly, looking like they were horribly ill, which they were. So we put them in oncology clinics and blended in there because a lot of other people there were very sick and looked emaciated and were sick, so that we would blend into the backgrounds to maintain, anonymity and confidentiality.
And also, 20 years ago, when some friends of ours were dying, the AIDS wards in the hospitals were pretty awful places. They had entire floors, and I forget the hospital in New York, but
University Hospital.
yeah, where lots of times families would hire private nursing because they weren't getting the proper care in the hospital. Or I remember one room walking by where the nurse's job was to hold the door shut because the guy kept trying to get out. It was, it was like,
And there was a
And
lot
we
of...
would have friends that we would visit, and we ourselves are thinking, okay, this is our future, I guess, but we were there to help our friends die, really, be with them when they were dying. And you'd go for a walk to take a break, and every room was a chamber that you kind of, I can't tell, I would be invited into rooms to witness a signing of a will. Some woman who was on her way out and her family was there and they had to have a witness to sign. Things like this, or what Tim was talking about, it was against the law to lock somebody's room. But this often drove people crazy. It made there is a advanced dementia element of this. And you know how there are little windows in hospital rooms sometimes, in the door, and there was one, but there were two, but one in particular of somebody who was just really around the bend mentally and was trying to get out and was pressed against that glass, and the nurse had to sit in a chair with a towel wrapped around the handle so she could get leverage on it, so he couldn't open it up from the inside. That's what he was trying to do really hard. And to see, and his face was in the glass trying to do that and screaming and everything. It was really hard to keep your equilibrium during those years, It made you frightened for yourself, but also our job was to be helpful and supportive to the people who were checking out, who had been our friends for years. So it was.
If I may, it's 20 years ago today that my brother died of AIDS at Fletcher, and we never experienced anything like that.
Yeah.
And I'm pleased to hear that. Fletcher Island really did well with that, but there was, early on, there was some issues. Some of the housekeepers, for example, would refuse to go in, or they put the food trays on the outside and refused to go in. But we made decisions early on that, and all people with HIV were put in private rooms.
We had a private room, but we had a big
Right.
red scarlet letter on the door, but that
Correct,
was it.
and we stopped that. It took a while, but we stopped that, and we put people in two-bedded rooms to block that. But in a lot of institutions, and I must say another anecdote of our surgeons, a lot of the surgeons in other places refused to operate. Our surgeons operated on folks. And I remember the chief of surgery, a guy named Steve Shackford, a fellow of mine came in with essentially a T count of 20, appendicitis, needed his appendix taken out, and everybody's going, oh boy, what's going to happen? This is a long time ago. Will he be operated on? And this guy, Shackford, the chair of surgery, just said, damn it, we're doing it, let's go. And that stopped it. And that was such a role model, and Fletcher Island really teamed up. But in other places in the United States, that was not happening. There was a huge amount of discrimination.
This is what you saw.
Yeah.
And Chris is not one to sing his own praises, and it wouldn't be in his normal bio, but maybe you could insert it as a bullet in the future. I don't know what makes him so frightening. He's not particularly frightening to us. He's a kind and gentle person, it seems to us. But way back then, he was very clear with us, and so was Deb, that if we were to find any kind of stigma or prejudice from a dentist or a doctor or somebody who seemed to be hesitant about caring for us, we just were to report it to him. I don't know what he did. I don't know what he did. But it would be it stopped. They couldn't do enough for us.
But just to,
It's that horse head.
We didn't have speed dial, but I'm sure my father had Chris's number on speed dial. Any question was addressed compassionately and thoroughly.
thank you. So just to finish this section up, if I could, the other, again, I think the issue that this is a horrible infection, but we saw brain infection. So this is a scan of the brain. There's a big abscess right here. That could be all sorts of ugly things. Toxoplasma that you would normally see. It could be a lymphoma. It could be a lot of different things. Extremely difficult. And you can see a big one here, smaller one here, smaller one there. Very difficult to treat these things. We were biopsying people's brains, using a lot of difficult stuff. And then one of the most awful things, and thank God this has stopped, this is the back of your eye, your retina, and this is normal retina here. The optic nerve comes out right here. This is all blood, and this is bleeding into your retina. And this is due to a virus called cytomegalovirus. And these men would get this, and they would go blind. They would go blind. So here you are, you're 26, 32 years old, and you go blind from this. And the therapies we had were awful, and they didn't work very well. And the number of people who got blinded from this, along with having these things and other things, was huge. And this was our daily fare in clinic. and in the hospital. And then finally, sort of the end stages of this, in Africa, this is called Slim's disease, from the wasting. And this was also not only somebody basically starving to death from multiple types of infections and tumors, but this was also then an obvious stigma of that you're sick. And so this would go on and on. I'm just going to skip that just to say that then things turned around. So I'm going to pivot again for a moment. And things turned. And they turned in about 1986. So we had 2 or 3 drugs out at that time, AZT, another one called 3TC. They had some efficacy, very limited, very toxic. And then in 1986, these new drugs came in, and it was a game changer. This is the drugs we have now. So remember, 95, 96, we had 2 drugs. Now we have in the territory of 30, and not only do we have, here's AZT right here, but in this class of drugs, we have numerous drugs and combinations, and then all sorts of different drugs. So our armamentarium blossomed. Again, a credit to the basic science and the scientists who have worked on these things to come up with this. And this is what happened. So here you are, 92, things aren't going so well. This is when these first drugs came out. And you can see that, the number of people, the amount of opportunistic infections, these brain infections, the pneumonias, the eye infections, basically we're coming down a little bit with the older drugs. And then once these highly active antiretroviral therapy came out, here, boom, they plummet down. And we can control the virus with these drugs. And we can take that virus and turn it off. And we can take that viral load from 200,000 copies, 300,000 copies, 1 million copies, and we can drive it down to non-detectable most of the times with these drugs. And what happened is that people stopped dying. And I don't know if you guys wish to comment about that pivot, or Deb.
It was, you can imagine, you're hanging over the edge of the abyss, and the rope is fraying pretty much, and you're about to, go. We both felt pretty close. I felt really close at one point, and then just coincidental. These drugs happened, and it was a complete turnaround for me. I gained weight back, and I became thinking, I became my old self again. But it was really close. I do have to say that once you, and I'm sure with other diseases, it must be the same thing. This must happen to a lot of people for all kinds of reasons. But once you look over the edge and face it and think, okay, this is what this looks like going down, that never leaves you. You don't really want to look over that again, and we still don't know. Things have been working out. We're very grateful. We couldn't believe we'd ever be Medicare people, but that danger is still there. We don't know really how long these drugs will last. They don't last forever for some people.
This was a time, too, when I think back, when there were insurance companies, people were buying your insurance policies. There was the viaticals. There was a lot going on. That was one
The life
case
insurance.
when they came out, they lost.
Buying life insurance policies.
Yes, yes. You could sell your life insurance policy to somebody, and them being sure that you'd be dead in a short amount of time.
And up until that point, the insurance companies were right.
Yeah,
That
right,
you would be
exactly,
dead.
yes.
And so the gamble was, correctly, they buy your insurance policy, whoever gets a little bit of money,
Yep.
and then you're dead, and they make out like a bandit.
Yes,
Until-
exactly.
Some of our friends were able to pay their medical bills and to not be kicked out of their apartments because they sold their life
Yeah.
insurance policy,
Yeah, yeah.
And they didn't have any heirs. They happened to have this life
Yeah.
insurance policy through work or something. I don't know. It was, the viaticals got a bad, they made out like bandits and all that. It's true. But some people were able to survive financially for the couple years they had left by doing this.
Right, and then the beautiful irony of this whole thing is that when these drugs came out, people stopped dying, but they still had sold their insurance companies, and so they got all the money, and the insurance companies then still had to pay into that. But and
So, as Chris mentioned, when we first started doing this, we did hospice. I think we did it pretty well, but that's what we did. And we actually had a hospice nurse as a permanent member of our team. And we had a dietitian who used to fondly call it the Dr. Grace diet, which was eat anything you want, whenever you want, as much as you want, because people were wasting. And, you know, she was giving people high caloric, high fat foods all the time. And her job now is to help people lose weight.
Or lower cholesterol.
And lower cholesterol,
so
absolutely.
I'm gonna use that as a pivot if I can, because we got 15 minutes left to cover so, you know, this is, we've talked about quite a bit that prior to 1996, basically you're dead. This is a picture of the Washington Mall. These are the quilt projects, and these are all quilts made by family members of people who have died. We had our own here of one of our patients. So that was what was going on. Deb and I spent a huge amount of time out at the Respite House, which is a great organization. And this is what happened with these drugs. So we had these early drugs that sort of worked and they were okay with something, but then basically not working so well and people were dying. And then 1987, these drugs started coming out, and a lot of them came out, and they are still coming out. And we started using 2 and 3 drug combinations called highly antiretroviral therapy, and it was a godsend, and it really switched that around. And not only did the efficacy and the potency of the drugs, but the number of drugs that we had started working. And so what happened was that we were doing this, and all of a sudden it's like people stopped dying, and the opportunistic infections started going away, and this turned into a chronic illness of people surviving with this. And I think Tim and Brad are excellent examples of people who forged through this and survived. And it really, really changed it. Not only did it change from that point of view, but early on with these new pills, and you guys please comment about this, it was very difficult. These drugs worked, and they were very potent, but people were taking literally 30 to 45 pills a day, some with food, some without. They all caused diarrhea. And you had a lot of rashes. And so, yes, they worked, but they were challenging to do. And people got sick from their medicines. And I will not show you pictures of that, but people would get disfigured actually from the side effects of the drug. And then the progress from, and you guys were part of that.
Well, and some of them were just plain nasty. Oh, God. One of them we had to crush and put in water and drink it. And, well, you know, many of you have had colonoscopies. You know, that colonoscopy is not so bad, but that thing before that it was like that, like twice a day we had to do that. And you know, okay, we have to live. We have to take this nasty stuff. But it was an unhappy situation. We had tons of pills, and I've always wondered how people, you know that people who were stable and we have very organized and everything, and it was hard to keep everything straight. But wonder if someone is
Living on the street?
Living on the street or an IV drug. I mean, how do you keep, even now, I mean, if you have to take them maybe 3 pills, but 2 in the morning and 1 at night, or I don't know, or something. And some pills are still no walk through the park. Tim had to get off one. I'm still on it because because I like horror films. It creates it creates actually vivid, violent dreams. And so for me, it's like I go to the movies every night, see Scream 73. I don't know. But it's a drug that just allows you to wake up in a cold sweat every night and think that you've been to a really great show.
But
Tim was on it for 2 days.
Trying, but what we are having now, and I'm sort of jumping a little bit and sorry to interrupt you, but we are sort of running out of time. You know, now we've gotten to the point that we are treating people with 1 pill once a day. These are combination pills that have 3 medicines in them, but we've gone from 45 pills a day to 1 pill. So not only have the drugs gotten more potent, but they've gotten easier to take, and as you can get a sense that if the pills make you sick, you're not going to take them. And taking 2 pills a day, pills twice, 3 times a day just doesn't happen. So It is revolutionary. It doesn't mean it's perfect, but it has made a lot of
And the reason
progress.
that we're still taking a number of pills is because we've run through a lot of pills. You know, where if you're new to it, you don't, that's something maybe
Right.
that's not necessary
So-
to talk about, but you become resistant. The pills only work for so long, and you've got to move to another class of pills.
So what has happened with this? This is a similar slide. This is, the number of deaths, and you can see in the early it's going up, up, up. Here is the highly active retroviral therapy, and the death rates have come down. Hasn't gone away, they have come down. And just quickly looking at this is looking at deaths in the United States through various reasons: heart disease, suicide, homicide, and HIV disease is in red. And you can see in the early years, this is 87, 88, 89, 90, going up, 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 up. These new drugs come out, and it basically is plummeting down. It's a miracle, and it's literally like a light was switched on in terms of the efficacies of these drugs. And I think most people in the United States are very fortunate to have gotten these things, and the idea is to get more people on these medicines if we can, though it's not easy. It is not easy, but they do work, and you can see that. So I'm going to pivot again. Any other thoughts here? So this is something that Brad had brought up, which is, how we now have these medicines. In the old days, it was an issue of how do we manage these terribly sick people in a rural area. People lived 2 or 3 hours away in the old days, and Deb, comment if you want. People were driving up from Brattleboro to Burlington, trying to get up here in the wintertime, coming from upstate New York, driving 3 or 4 hours, and it was difficult, and therefore people were not getting their care. And this is sort of what the model looked like, is just, you have Dartmouth as a university program, us as a university program, and these blue bars, arrows, are people traveling all over the state to get their care. And then try to manage this stuff long distance was really not working, and this model was not working. So what we put together was that slide, which is here, we still have people traveling, but we have set up 3 other clinics in the state. So here's our main clinic here in Fletcher, Allen, but we now have a clinic in Rutland, started in 1994, Brattleboro in 1995, and up in St. Jay's in 96.
Chris, how much is this model in other states, other rural states?
Well, I don't know that. I think it's quite common to do an outreach, and it's not just HIV. People can do that in oncology, and they can go from here to a smaller hospital in the state. So doing a university-based outreach program, I think, is not uncommon, and I think it is pretty common. I think once you get into more rural areas, like even in sort of North Dakota, Montana, they can't do this. The driving is too far, because we have the doctors, the dietitian, the psychiatrist traveling to these clinics. And each of these clinics we, though, have based there is a nurse or nurse practitioner and a social worker. So we have a team on site there. And I must say, in view of what you were saying about Fletcher Allen, being good and stepping up to the plate, these hospitals, Rutland Regional Medical Center, Brattleboro Memorial Hospital, and Northeastern Regional Hospital, have been huge. And the CEOs of these hospitals, when we approached them to open these up, just said, we're there, anything you want, anything you want. This was about 1994. So this was about 1987 in Burlington, 1994. So the CEOs and the hospitals in general were superb, and I think that's a credit to the state of Vermont and the people who work here. We had mentioned Ryan White. Ryan White, just to show you a picture, this is Ryan White. Here, he's a little boy, hemophiliac, and got infected through blood transfusion, and he was diagnosed and then terribly discriminated in Indiana, was thrown out of school. And his mother, Jeannie, basically became sort of the super advocate. And before that time, the advocacy was all through the gay community, a very strong advocacy, which pushed a lot of the good things that we've been talking about here. But, and forgive me and talk about this, but, being gay at that time and now generally was not socially acceptable. And to have an advocacy group and to get money from the federal government based on, say, like a sick gay man was just not going to fly. So they latched onto this little boy as the symbol of the AIDS pandemic in the United States, because everybody could look at this and feel bad. And so the funding streams that came out of the federal government to provide care, set up clinics, was named after this little boy, and that's where the title of the Ryan White Care comes from. And I just want to take 1 second and give a call out to our own congressional staff, not only the current people, but Senator Jeffords was the chair of the committee that ushered these bills through the Senate and the Congress. He was in the Senate. And he was an incredibly strong advocate here for Vermont and the United States. And, you know, I think it's one of these unsung heroes of the pandemic, particularly here in Vermont. He pushed a lot of money into rural states, and it has helped us immensely to get this done. And this is sort of the process that we put together. Here's our 4 clinics. And, you know, Deb, please jump in if you would. But a lot of surveys were done, and we went and visited a number of hospitals.
And again, as Chris said, it was truly amazing how welcoming people were. I mean, we had fears that we would go to these hospitals and they would say, don't bring us your, we don't want those patients, get out of here. And in many cases, what they said was, we would like you to care for the patients. We don't want to do it themselves. So in Rutland, again, we were in the oncology, the cancer centers in each hospital. In Rutland, across from the cancer center in the building is their cafeteria. And it appeared when we got down there that part of what you did in Rutland when you had nothing else to do is you would go to the hospital and you would eat in the cafeteria where the food was not bad and sit there and say, oh, look, Aunt Millie's got cancer. And, oh, did you know that, your neighbor was into the cancer center? And we thought, this is not going to work. And they frosted the window for us. They just said, okay, if this is important to you, we'll change the window. And it happened in hospital after hospital that they just said, okay, we can do this. And there was certainly political debate, and there certainly there were issues of us being, from the big city in Burlington and coming down and doing care, but mostly people were incredibly friendly. We had very good support from the local aid service organizations. In fact, in Brattleboro, they were the ones who asked us to come down. And we still have incredible support from those hospitals.
So in a few minutes, I'm just going to sort of move along, sorry. So this is what we're looking at. This is in the very beginning. These are the numbers of folks we have. And I'm guessing that Tim and Brad were probably either second and third in there. But, big jumps that have occurred, and that will continue. So I'm just going to skip that. So what is the future here? What are we looking at? What are the changes, at least in the United States? This is looking, though, at the world, and this is particularly in sub-Saharan Africa. This is 2009. Hopefully that's changed a little bit. 7,000 new infections a day. A day. So this is not something that is historical or it's going away. This is still an active pandemic. A fair number of them are young children and young people. So this is not going away, either in the United States or in the rest of the world. And this is a complex graph, again, showing the number of people here in the blue living with diagnosed HIV, and you can see that's going up as we've shown because these drugs are working and keeping people alive. But the gray part of the bar is the number of people with undiagnosed infection. And that's a huge problem in the United States and worldwide because these folks are not getting care and they are transmitting or potentially transmitting this infection, contributing to the ongoing epidemic. So that has to be wrestled with. And this is, again, showing the challenges that we're facing in the United States. So, it's estimated about 1.1 million people have HIV. Those who have been accurately diagnosed, you can see the number here, linked into care. Now we're falling down you're falling down by 250,000 people that are out there that are not really strongly linked to care. Why is that so? It was brought up before. It's probably related to poverty. Retained in care, half the people in the United States diagnosed with HIV are retained in care, half are not. And that means they're not getting adequate care. For them, they will potentially get sick, that increases costs. So when we have somebody come in late and they're admitted to the hospital, it costs a huge amount of money to the medical establishment, if you would, and to healthcare services. Those people on active antiretroviral therapy, less than half in this country. This is this country. We're not talking sub-Saharan Africa. In this country, less than half the people who probably should be on these medicines are on these medicines. And then who are on these medicines and have had their virus suppressed, which is the goal, is to knock that virus down to zero, if you would, say 300,000 out of 1 million, a third. Not very good, not a great track record. So despite the effort that has gone in this country, the amount of money, the pills we have, the successes we have had, there's still a huge amount of work to be done.
And Chris mentioned it before, and you may have thought before, like, well, so if you can't do anything about it, back in the old days, why would you get tested? Or even today, why would you get tested? It's because you also have an obligation to make sure that you don't hurt anyone else. If you don't know, you don't, it's hard to take care. And so I think people have, people have a moral obligation to find out that their status, unless they have married the person that they've only had sex with from high school, and that person that you've married has never lied to you about you being the only person that they've had sex with. I'm sure that's everywhere out there.
So what is,
There's a question right there.
Yeah.
sorry.
Just, how much does the test cost, and why hasn't it become part of just a normal test like you would have your cholesterol tested or whatever?
Okay, I'll be interested in your thoughts on those. I'll tell you my opinion. One, how much does it cost? I would guess a couple $100. Should be paid by insurance. And currently, and this came out probably 5 or 6 years ago, the federal government, the CDC, said everybody should get tested. Why is it not done? I'll give you my opinion, because this is still a socially unacceptable disease that's linked to being gay or stereotyped into injection drug users or heterosexual, or multiple heterosexual partners. These are all things that are socially stigmatized in our country. So I still think, despite 30 years of good work, this is still a terribly stigmatizing illness. And oftentimes I will say to somebody, as a general infection specialist, and I'm working up their fevers or whatever, and I go, listen, everybody I see, I test for HIV. I'm going to go ahead and do that. Is that okay? And they go, sure, I haven't done anything wrong. And there's that there. And not only is it in the patients, you that I might talk about, but it's in us, the docs, who don't want to talk about this. And it kills me. It kills me. The docs won't bring the topic up, despite what you say. And it's very frustrating to see young, predominantly men, coming in this day and age with no T cells and these horrible infections because they weren't tested soon enough, or they didn't get themselves tested because of the fear. I saw a young man today.
That's a big thing, I think.
I saw a young man today, newly diagnosed, and that guy was jumping out of his skin in fear that somebody was going to find out. Somebody, his mother, father, friend, coworker, terrified. I mean, in tears today. This is today. So there's a lot of fear about the illness. There's a lot of fear of somebody will find out who I am, and then there's a lot of stigma going on. It's a terrible situation. It's not, go ahead, I'm sorry.
Yeah, I was going to say, what about the self-testing? Has that changed?
So the question is, you can go into a pharmacy, and we're also now formally 3 minutes over. So
when you walk out of this room?
yeah, so I'm more than happy to continue this conversation. Since we're going to buy dinner for these guys, they're going to stay. So you can, what's that? So what Brad was referring to is that you can buy a test kit and prick your own finger, put it on a paper disc, and you can buy that in the pharmacy and send it in, and you can self-test, and no one knows. How much of that's done, I don't know.
Well, we just actually, we have 2 new patients
There you go.
who got tested that way. I think So I've spent a lot of time in the last few years talking to physicians about HIV testing. We have a small grant to do AIDS education and training. And what has been remarkable to me, particularly among OB providers, so if we looked 7 years ago or even 5 years ago, only 70% of women who were pregnant were HIV tested. And naively, I thought that if you were a pregnant woman, you probably had unprotected sex. It's a feeling I had.
This is why we hired her.
I
So
know these things.
I'm going to interrupt because I think the hook is coming out pretty soon.
Yeah.
Just to sum up with where we are as a country in terms of thought processing, and it goes back to your question, which is everybody should get tested. The reason being is if you get tested, you can get the care, we can suppress virus, and it has now been shown with very good data that if you go on these medicines and we can suppress your virus down to 0, which we can, that you will not transmit, or your risk of transmission is almost negligible. So the whole thing here is that not only is there treatment to control HIV, but now treatment is being used as a public policy tool to prevent transmission. And I'll just finish up with this slide from President Obama and when Secretary Clinton was still Secretary of State, that they came out a year or so ago and they were talking about an AIDS-free generation. Now that was wildly optimistic, and that's not going to happen in the near future, but what they were talking about was this paradigm shift of using treatment as a public health tool and recognizing that all the work of, use condoms and so on was good, but it's not working. And the idea is you test early as you can, test everybody, get everybody into care. If they're positive, treat them, suppress virus down, and then transmission stops. And I think that is the future. And, realistically, that's probably the only way we'll bring it into this. So that, you'll be pleased to know, it's my last slide. So is there any other questions? Because we do have to finish up.
Come walk down.
Okay.
That'll be the formal end.
Okay.